In a dusty rural hospital in northern Tanzania, a young woman requires emergency surgery. A ruptured appendix is suspected, but Jabai Mukum is alarmed when he slices into 27-year-old Rahel Rubin's abdomen and finds a widespread toxic infection.
Actually, it was frustrating because the end result is septicemia. Septicemia is the killing situation, you know. The bloodstream, that septicemia, that means the spreading of the bacteria through the bloodstream. So the end result is death, obviously.
This patient's heart was failing before surgery. This impoverished hospital had only the crudest operating room tools. It's a wonder this surgery was a success. What's more amazing? Jabai Mukum is not a medical doctor. He's Tanzania's version of a physician's assistant.
It was a very difficult procedure. That's why I'm sweating, you know. Difficult. Yeah, very difficult procedure.
In fact, at this crowded district hospital in Kahama, Tanzania, where patients double and even triple up on beds, there's only one fully trained physician for a population of 800,000. He's Dr. Leonard Subi, and he works mainly as an administrator.
For a medical doctor like me, for the time being in the district, I'm alone. I'm alone, the district.
Tanzania is terribly short of doctors to treat its more than 40 million people. And the government has been working hard to get trained medical personnel even in the smallest communities. But with Kahama's vast population base, the hospital must make do by relying on assistant medical officers, like Jabai Mukum, to fill the gap.
These assistant medical officers, they are doing other work which should be done by specialists.
This we call task shifting. Someone who is not a doctor doing a job of a doctor. And that is what has kept us alive.
Tanzania's Minister of Health, Professor David Mwakyusa, explains how his country struggled to meet its healthcare needs.
In the US, if you feel ill and you're taken to hospital, you are going to meet a doctor. In my country, that's a luxury. A lot of people have gone to their graves without meeting a doctor. And so we need doctors, but we really don't depend on them only.
Instead, Tanzania looked to its clinical workers, some with the equivalent of a 7th grade education in the United States, and sent them back to school.
We designed a system where we've been training people to cadres which are less than doctors, less than pharmacists. You'll find a clinical officer who was actually a primary school leaver. He goes to school, to a training college for 3 years, becomes a rural medical aide, or later he becomes a clinical officer. These ones, you teach them about malaria, for instance. You teach them about the common conditions. Most of the common conditions were infectious diseases, you know, top 10 diseases we call them. So they become pretty proficient.
Despite their proficiencies, assistant medical officers, or AMOs, face daunting odds. By the time patients with little money and no transportation finally make it to a district hospital like Kahama, they're quite ill, having delayed care. Many are pregnant women in labor with complications. AMOs do cesarean sections all day long, and many have become quite skilled at them. Still, maternal mortality rates remain grim. At least one mother a week dies in childbirth at Kahama's hospital. In Tanzania as a whole, a mother dies every hour. Tanzania's medical deficits go well beyond a doctor shortage. There are too few nurses, too little equipment. One X-ray machine serves 800,000 people.
We need good diagnostic equipment to make sure that we diagnose patients very fast, we give them right treatment, okay? But all these things, they need money. They need money.
And while money is ultimately the problem, the Tanzanian government has pledged millions to upgrade health care and graduate more medical doctors. The country is poor, and salaries are stunningly low, less than $200 a month. Dr. Alfonsina Masco Nanai left patient care to work on HIV prevention for an NGO. She's now paid 10 times more. But Dr. Nanai said a lack of support staff was also a factor.
The staff are few, so the burnout is quite high. But if it would pay better, I would think of going back.
The government hopes its plan to train more medical support staff will ease the burnout now felt by doctors in public practice. And in the meantime, new doctors are coming online for Tanzania. An organization called the Touch Foundation was created solely to help Tanzania's doctor and health worker shortage.
You have a mother with possible signs of IDS who's coughing for 3 weeks.
Financed mostly with private and public money from the United States, Touch created a medical school at Bungando Medical Center, one of Tanzania's largest hospitals on the shores of Lake Victoria. The new school, which is also supported by Tanzania's government, now has 800 Tanzanian students and plans to double the number of doctors in the region. The foundation hopes to capitalize on money pouring in from the global community to help with diseases like HIV, tuberculosis, and malaria by emphasizing the need for medical doctors to treat those diseases. Lee Wells is the executive director of the Touch Foundation.
If we care about HIV/AIDS patients, if we care about malaria patients, infant mortality, all of these really crucial areas, then we ought to care about how that care is delivered.
For all the successes Tanzania has had with its assistant medical officers, or AMOs, their experience can't always match the knowledge of a medical doctor, as was the case on morning rounds at Bungando. Dr. Robert Peck, a doctor on loan from Weill Cornell Medical College, discussed with his medical students the case of a malnourished baby who was sent back to the hospital after being treated by AMOs.
When you have severe malnutrition, one of the most important things is to think about the cause, to ask why. Because if we don't know why in these children with severe malnutrition, when we treat them for malnutrition, when we discharge them home, what is going to happen? That's right, they'll develop severe malnutrition again. What often happens for AMOs is because they're so busy, because their training is limited, they think of first things first. They think of malnutrition, they treat the malnutrition, and in this case it didn't get better. What other things, other than socioeconomic factors, can cause malnutrition in a child this age, severe malnutrition? HIV, very important.
The baby, it's determined, likely has HIV and tuberculosis, making it tough to keep food down.
The AMO training is very good for what they do, taking care of patients on a practical day-to-day level, but they don't have the time to learn the pathophysiology, to really understand the diseases as well as the medical students do, because they simply don't have as much time in their education.
A study released in August showed Tanzania's health worker shortages are part of a bigger problem. According to the Journal of Health Affairs, Africa has only 30% of the 1.16 million doctors, nurses, and midwives it